Good morning, everyone, and welcome to this TIRO multidisciplinary seminar. Welcome to the month of March. We have a wonderful panel this morning to discuss a really important topic that has come up on numerous occasions during the past several sessions, talking about the risks associated with post-ablative procedures of performing surgery. And we have truly one of the experts in the field, Dr. Emad Kandil, who is a professor of surgery at Tulane Medical Center in New Orleans. Dr. Kandil is the Elias Hanna Endowed Chair in Surgery. He is also the Chief of General Endocrine and Oncologic Surgery Division. In addition, he is the director of the Clinical Endocrine Surgery Fellowship, which is a fellowship that is highly regarded. He has a robust academic career, having published 300 peer-reviewed publications, as well as lecturing both nationally and internationally. He has been involved and has held and continues to hold leadership positions in multiple national organizations, in addition to the tremendous work that he does down in New Orleans. He founded an annual course on thyroid and parathyroid surgery that is in its 11th year. He has special interest in robotic thyroid and parathyroid surgery. We are joined this morning by Dr. Lisa Orloff, who is a frequent presenter at our weekly TIRO sessions. She is a professor in the Department of Otolaryngology, Division of Head and Neck Surgery at Stanford University School of Medicine. In addition to directing the thyroid tumor program at Stanford Cancer Center, she is also director of the AH&S Fellowship Program in Endocrine Head and Neck Surgery that is located at Stanford. Dr. Orloff is widely recognized for her expertise in the use of ultrasound for both diagnostic and therapeutic intervention. Her textbook on head and neck ultrasound is in its 2nd edition. In addition to her leadership role in the ATA, where she's currently completing the updated clinical practice guidelines for the evaluation of thyroid nodule, she is also an active member of the TIRO Medical Board. So with that, it's really a pleasure to have Dr. Kandil present an important piece of work discussing the topic that we talked about at the outset. And then Dr. Orloff will discuss this paper and provide some perspective. And as always, we ask that all of you send in your questions during the session. I'll do my best to get to them before the 9 o'clock hour. And so with that, Dr. Kandil, thank you so much for joining us and looking forward to your presentation.
Thank you, Dr. Erkin, for the opportunity. It's an honor to be here today. I believe I've done a couple of presentations before on this platform, and it's really a fun experience and a great honor. I was asked to talk about the experience with thyroid surgery after ablations this time, but this time though the paper is really kind of like a small paper, so I thought I'll just make a little agenda, go over a little bit of basics and indications and why we do this, and then eventually get to the paper and the future. So with radiofrequency ablation or any ablation, and now we do also microwave, is the whole idea is to provide a cosmetically appealing procedure with significantly lower risk compared to surgery, and definitely can be done under local anesthesia. Having said that, some people like to do it under conscious sedation, which is reasonable, but there is no need to do it under general anesthesia for sure. But the main advantage of this is the preservation of the thyroid function for sure. It's definitely, whatever it is, just an outpatient procedure, and patient just literally can even catch a flight after the procedure. So the whole idea with the radiofrequency or even microwave ablation, it generates this significant heat that will cause irreversible cell death and tissue coagulation and tissue destruction, and eventually the body will absorb this destroyed tissue. There are different probes that can be used, at least for RFA. For microwave, there is only one size.
Emad, we're not seeing your screen. Perfect.
All right, thank you. So there are different probes for the radiofrequency ablation, and we tend to use the smaller probes for smaller nodules and the larger probe for larger nodules to generate more heat and more energy. And we deliver 1 joule per second, and you can literally go up on the power from anywhere between 20 to 100 watts. I also found out that different machines, usually the average use watt is different. So you need to be aware of your machine, etc. But you can keep increasing to get a real response, good impedance, and what you look for is the bubbling effect on the ultrasound. But the more time you stay there, the better the effect, and we're going to show something about that soon. But we look at the impedance, and the higher the impedance, the better the results. If the impedance really go very high, like near 1,000 ohms, for example, the system will shut down. For the interest of, I was going to show the machine here.
Hello.
But basically,
with that, you have two things of tubing. You're going to have first a blue piece of tubing that'll get put into the pump itself.
So there is the
Also connected to the electrode, and this is for the exit of the cold water.
But because this is electrical energy, we've used
Hello.
electrodes like the Bovi electrocautery, but there is no electrodes for microwave. When we do this procedure, can generate significant heat, so it's recommended to do some hydrodissection. And that can be done with D5W. Some prefer using saline. But as you can see here, here is the thyroid, here's the carotid, and with the needle here, you just inject the fluid and create a significant space between the carotid and the thyroid or the thyroid nodule. So you can see here a nodule and the significant space created to just keep it away from harm and keep the carotid away, and the carotid sheath in general with the sympathetic chain, etc., because of the possible complications that can be done with the heat near the carotid sheath, sympathetic chain, Horner syndrome, and all that. So I like this paper. They looked at significant hydrodissection with the large volume versus low volume. And they found that if you burn a huge nodule with a very large volume, it can be beneficial. They did not really show a difference between the low volume and high volume, but they really tend to use the high volume and high thyroid nodules. So it's recommended to do I think this is really important for the approach, because what I do is different from what's recommended by most. But I learned by looking at others that everybody does it differently, and I'll show that. So the recommended approach is a transisthmic approach. When you come from the isthmus and one entry, single entry, moving shot technique, and you burn the nodule, you stay away from the dangerous triangle where the nerve entered into the cricothyroid membrane, and you generate the heat, and you just keep moving with the moving shot technique to burn the nodule. And you can adjust from the single entry your probe inside the nodule using the ultrasound, and you with expertise you're going to make sure that you will really burn the entire nodule. And if it's not, you might want to do another entry if it's a huge nodule, etc. But what I like is the lateral approach. And it's interesting that most people in China, they actually do the lateral, and they come completely from lateral. So I did not know this except recently. I thought the lateral approach is a good idea because I'm away from the dangerous triangle, and I try to stay completely safe first before coming close with the medial approach from the dangerous triangle. But I just learned that people who've done thousands of these in China, they actually prefer that approach too, which is interesting. So I'll just show you here a quick video for the methodology and how we do this. But this is here.
I'm going to start with what's color on this.
Nodule, but the large one that enlarges vascular.
So you can see here it's a very vascular, not 2 millimeter probe. I set up here the machine for 25 watts.
And you definitely
And
can
I'll do
increase the
a
loss of-
moving shot technique, but with a little bit more medial. You can see the tip of my needle here. I burn the capsule, start
So if it is cancer, you go
inferiorly,
outside.
and I'm waiting for the bubbling.
Safe for curing.
Now, once
And I
I
like
see
to
bubbling, I
look at
start
the
to move
impedance.
back.
Seeing somebody playing with the impedance, and I just keep moving here in the nodule. We look at
And
the
I'm
bubbling
listening
side.
carefully to the number and watching for the numbers, how
I
much
like the
ablation I'm
impedance to
getting.
be really high before I move, not just looking at the bubbling side.
And the
Aside,
patient is
because if I
tolerating this
can
very
listen
well.
and-
Can you please say E? I'm gonna throw.
I actually right now I don't talk to patients as much as long as I'm away from the dangerous triangle, because I feel there's no point and you can do it safely. So many data, many papers were published on this, and the reported response with a volume reduction rate is over 90% in some, but an average like in the 70s, depending on the size and depending if you're treating cancer or not. I'm going to touch base on this. This is I like this study because it's multi-institutional from Italy. And what I like about it that you need to really spend more time talking to patients, a lot more than when I sometimes do the procedure. But I explain that eventually in the first few days they might experience some swelling and some discomfort, and eventually it will shrink over time. And you don't expect good results for like 6 months, then 12 months. We used to do like 1 month ultrasound. I don't do this anymore. At least 3 months, and we're going to touch base on this for cancer. Actually, at least 6 months to a year, because this is when you see results. But as most studies, this is multi-institution studies, show significantly low percentage of complications with a voice change here, 0.4%. They had one nodule infection, which I think one of the worst complications that could happen. One of the largest published series from Dr. Baek from South Korea, 1,500 cases, and you can see again the voice change in 1.4%. They had 2 ruptures and that series, which it's a good thing. But you can see also there are reports of brachial plexus injury from someone experienced like him. And when somebody asks him about thyroid function, usually it does not affect what you can see. There's some reports in the literature about hypothyroidism and even hyperthyroidism, and I've seen hyperthyroidism. There are reports of like nerve injury due to hematoma. I'm not sure if it's a hematoma. I believe the thermal injury. Sometimes patients will have good voice immediately after the procedure, but the next day they will notice a change in their voice. So that's something to keep in mind when you do these procedures. This is a picture of a rupture, and you can see here outside the thyroid capsule and the subcutaneous tissue, the fluid, and it can drain into the skin. And I have multiple of these pictures on my phone, as thank God I've done over 1,000 of these procedures so far. I never had one yet. I think the key is to make sure you be careful near the capsule. But it's a terrible complication. And this is here a paper that looked at different cases and tried to do a literature review. And you're converting a nice case to a terrible complication here with something just to keep in mind. But the good news is, to my knowledge, there are no reported cases of need for surgical intervention to correct that problem. Usually they can be treated with just antibiotics and observation. And all the cases that I heard about from my colleagues in US, they were all treated conservatively too. The only cases that required, in my knowledge, surgical intervention, these like hematomas. So really precision is a key when you do these procedures for sure. So one of our first papers we published in Annals of Surgery with the combined data of Johns Hopkins, when we published the first 100 cases, benign cases, and consistent with what was published in the literature. But what the new thing here that we looked at, Lisa's the expert in ultrasound, but we looked at the elastography, and stiffer nodule did not respond as good. And we were consistent with what other people publish about vascularity. The more vascular the nodule, the less response. But what we noticed too, that age can make a difference. And I think because of the TSH, so the higher the TSH, we know that the higher the TSH can make nodules grow. So it did affect something a little bit. So we reported a few years ago on the safety of this. And with the Stanford group and Hopkins, we recently published in Surgery, just the paper was out a couple of months ago, over 600 cases of benign nodules. And what we show that the smaller the nodule, the better the response, and with more energy you deliver, the better the outcome, again, with a very low rate of complication. And what we concluded that smaller nodules, more energy, less vascularity have much better outcome. One of my favorite indication for this is the autonomous producing nodules, hyperfunctioning nodules. And this is one of my first cases that I've done, 80-something-year-old gentleman with significant morbidities. And it took literally a minute to ablate this nodule. And it did shrink over, eventually near close to 80%, but the key is his THH went really high and eventually normalized, and he did not need to be even on euthyroid medication. We published some experience on that, and they respond really well. There is many meta-analysis on this. The success rate can really be reported in some series to be near 100%, but what I tell patients on average is over 80%. But what we learned, this is a case here where you have hyperactive nodule and shrink, but the patient is not here for shrinkage, it's for the outcome. But what we learned, and I really believe in this because we're going to discuss this in my paper, that the smaller the nodule is definitely a predictor of successful shrinkage with toxic nodule. So if you have a large hyperactive nodule, these nodules, they might not respond as much and they might need more than one treatment or might have a recurrence. So I believe in that outcome that's reported by Spacia a while ago. What I like this paper because they looked at RAI versus RFA, and they definitely better outcome here on that paper with RFA. And in my opinion, I have issues with RAI in general and the complications related to this, so I'll pass on that. So thyroid cancer, in the paper that I have did not have thyroid cancer, but now it's a big indication that we use for PTMC and larger nodules. And there are multiple meta-analyses, and many studies showed 99% reduction, volume reduction rate. But I will, I mean, you need to understand that after the treatment, you expect significant edema. And if you do ultrasound the first month and maybe sometime by the 3 months after, you will have significant swelling. But usually the best results in a year, not before 6 months. I like this paper for different reasons. They looked at over 500 patients with the low-risk PTC. What's interesting, though, that 65% would be BRAF positive, and there was no difference in outcomes between the BRAF positive and not BRAF positive. And the TSH level did not predict response in their experience. We did some recent meta-analysis, and we found that the tumor will disappear in 87%. It actually will disappear on average in 99% if it's less than a centimeter. And that's really important to understand. The outcome is different from cancer less than centimeter over centimeter. And the tumor progression in general, 6%, again, is near less than 2% in PTMC, but in general, it goes higher with larger tumors, and the complication rates are significantly low too. For parathyroid ablations, I only do it if it's intrathyroidal or really inferior anterior. Again, make sure you don't injure the nerve. This one case where the patient literally, again, took a minute and the PTH, I did interrupt PTH and it dropped significantly. I think it's important too, because if you offer it, you need to know what's going to happen post-surgery. So let's get to the paper. We presented this in ES last year, and we looked at the outcomes for surgery following the RFA. And the idea is that there's this myth that if you perform the radiofrequency ablation or any ablation, it will cause significant scarring tissue and adhesions and make the future operation, if needed, hard. I think we are thinking of, for example, radiation therapy, RT or something like this, or some big intervention, or maybe prior surgical therapy. But there is really no literature. There's a couple of reports, etc. But it's just like a myth, really. So our goal from the study that we're talking about today is to look at the perioperative risk in patients who underwent surgery following RFA. And we decided to compare them to non-RFA. So we from over at that series, we had over 500 benign cases, and 23 cases had RFA unilaterally, and we included these, and then we included a larger population here. And this is what we presented is different from what we eventually published, but I like what we presented. But what's I want to highlight that the time for the thyroidectomy was around 6 months. And I think that's the key because we use a 6 month as also a landmark. If you just try to do a second ablation for any reason, you want to give it some time for the ablation to go away. So I really, this paper does not tell us, for example, what happens if you just immediately go after the ablation. So at least, as you can see, start from 3.5 months, but I think 6 months is a good time to like make things go away. So the indications, as you can see here, 3 patients had hyperactive nodule that were not cured by the radiofrequency ablation. Patient like to proceed with surgery. And 40% of these patients, 9 patients, had a regrowth or suboptimal volume reduction rate. 1 patient decided to just proceed, not happy with the outcome. And we usually have obviously a biopsy before the procedure, but I routinely repeat the biopsy again right before performing the radiofrequency ablation just to make sure I'm not missing anything. And interestingly, in 10 patients out of these, a lot of these patients, they come out of town, they did have some either atypia or follicular neoplasm, etc., and they have positive molecular markers. And that was not the case on the prior biopsy. So these patients underwent surgery. So when we compare here, we eventually make sure we match everything. We choose patients who had no difference in gender, race, BMI, and similar comorbidities and similar nodule size to compare apples to apples. And we had similar in that analysis, we had the similar thing with lobectomy, total thyroidectomy. There was no difference in outpatient surgery, and there was no difference in the operative time, which is the key. It didn't really take significantly longer time. And I can tell you, as a surgeon who performed these operations, it was not difficult surgery. It was not hard. Maybe in some cases you can tell there was something happened there, but it's not like it's stuck down or significant adhesions, or it's really a tough case or any of that. Here's the complication risk. I mean, it's a very low risk. None of these need, even the hematoma cases did not need a surgical intervention, just observation, but the outcome was very similar with expected rate of complications. When we did subgroup analysis for benign cases versus cancer cases, again, there was no difference in the benign cases that had prior ablation versus patients who just were virgin neck. And again, for malignant cases, there was no difference. And seriously, from experience, I did not see any difference. And that really made us look retrospectively on this prospectively collected data and study that, because it was just like a myth that I don't think it has any proof. So in general, in our experience, close to 96% did not need surgery when we do the RFA, but some for one reason or the other, as I discussed earlier, needed surgery. Complication rate was not different between the groups who had RFA prior to the surgery or not. And in conclusion, we did not see any increased risk of perioperative complications related to the RFA prior to the thyroid surgery. And maybe multi-institutional studies needs to be done. I've done also robotic surgery afterwards. And so interestingly, I'm aware of surgeons who did something like doing the ablation in order to shrink it so they can eventually do like a remote access surgery for a smaller thyroid. So the bottom line is, does not make it difficult, but you gotta give it time. What I don't know from this study as a limitation, if you go immediately after the ablation, does it look bad? I don't think so, but you might expect what to expect anyway, going after, for example, a core needle biopsy, like a hematoma or but I don't think it's just gonna show anything different because ideally, whatever burn you are doing inside the capsule. I think as surgeons, we need to know that this procedure is here to stay. And I know, unfortunately, a lot of surgeons are trying to make patients afraid from performing RFA because it might make future surgery if the RFA does not work for one reason or the other, that complicated. This is not the case. Patients are looking for it. Eventually, all insurance will approve this, and it really works, and the results are outstanding. So I like to say this. I used to say endocrine surgeon without ultrasound experience is the same as mechanic without his tools or her tools, but now without RFA is the same. I think it's something that surgeons really need to have on their armamentarium to offer it for patients. I thank you again for the opportunity, and I think maybe there's a lot to discuss when we talk about RFA. Thanks again.
Well, if I can proceed, then I want to applaud Emad on his work in general, this study in particular, but just his pioneering spirit and really demonstrating that it's really the sky is the limit when considering adopting new technology and new approaches to old problems. And he's really a model on the early adoption, but also to teach this and pass this on and share these new techniques with all of us. So I wasn't sure how much he was going to cover in radiofrequency for thyroid nodules in general, and he went way beyond that to discover some other topics. I will offer just some insights first and then some questions for Emad, especially about the study that he presented there at the end of his talk. I have, the only disclosure I have is that I've published this textbook, as Mark mentioned, on head and neck ultrasonography, which really is the foundation for doing procedures like radiofrequency ablation with ultrasound guidance. But in terms of thyroid disease and thyroid nodules, we know that nodules are extremely common and most are benign. And we can ask whether we're performing too much surgery, at least in the United States, for benign thyroid disease. These statistics are a little bit outdated. The numbers are probably higher now, but we probably perform more than 100,000 thyroidectomies per year for benign thyroid disease. And on that backdrop, and given the topic of today's discussion, I would just like the audience to consider in the back of their minds how we avoid overuse of not just surgery for benign thyroid disease, but also ablative procedures for nodules that might not actually need treatment at all. Nevertheless, the concept of thyroid ablation has emerged for a variety of reasons, as Emad outlined. In my experience, the number one reason that I see for patients being drawn to ablation is the desire for thyroid preservation, the desire to avoid removing a gland that is functioning especially, and along with that, the need to potentially take thyroid hormone after even thyroid lobectomy is minimized with ablation, but also just avoiding surgery in general, avoiding general anesthesia, avoiding a scar. There is a fear of complications, especially with voice issues, although complications are not completely absent with either surgery or ablation. As we have had advancement of techniques and equipment, and certainly propagation of information through the internet, patients are often seeking this treatment out ahead of those of us who are even learning about adopting it. But thankfully, there's been evidence of efficacy and safety of ablation. And the thought to possibly performing ablative procedures earlier in the course of disease to prevent bigger challenges later. So we are in somewhat of an infancy in our use of ablation in North America compared to Asia and Europe, where there is more than 2 decades of experience with thyroid nodule ablation. the FDA only approved RFA for thyroid tumor ablation in 2018. And we were fortunate, Emad and I and a number of other colleagues from around the world, to get together to draft an international consensus statement on the application of ablation, radiofrequency, and other thermal and non-thermal approaches for benign and malignant thyroid disease. And we hope that this can serve as a guideline for individuals looking to adopt this in their own practices, or to refer patients to those who often have the capability or the availability themselves. So the strongest indications for thyroid radiofrequency ablation for benign nodules are symptoms, mainly compressive symptoms or cosmetic concerns. And then there's also the application to autonomously functioning thyroid nodules or toxic nodules as an alternative to continuous medical therapy or radioiodine or surgery. The sort of sine qua non is to determine benignity, or at least historically that has been the first step in offering ablation for nodules, is to determine benignity through cytology, traditionally 2 benign ultrasound-guided FNAs, or if a nodule has classic benign features such as the spongiform nodule shown here, then a single benign FNA has been considered acceptable. On the other hand, for toxic nodules that are autonomously functioning, the risk of malignancy is so low that a fine needle aspiration biopsy is not mandatory. But some caveats and considerations when approaching RFA or other ablations need to be kept in mind, and these include the fact that a nodule is going to be reduced but not eliminated, and there is the potential for regrowth and need for additional treatment, especially with larger nodules. There's the need for continued ultrasound surveillance, there's potential complications, and there is a lack of definitive histopathology. And Emad alluded to the unique complication associated with thyroid RFA that is not something that we see with surgery. This is an example of a patient who experienced thyroid nodule rupture. And as Emad did mention, and our group has also concluded, that the majority of these instances can be managed conservatively. They are usually sterile procedures or therapies that may not even require antibiotics, but you resolve spontaneously. However, they may result in fistulization and actual extrusion of product thyroid, which does lead to volume reduction of the nodule, which was the goal in the first place, but also can be a prolonged healing process that can result in some scarring, or at least some patient distress that requires ongoing support and management. So Emad showed examples of the radiofrequency ablation procedure. The more commonly used approach, I think, is still the transisthmic approach, or analogous to the long axis approach of doing fine needle aspiration biopsy, with the advantage here that you can see your needle or your radiofrequency probe throughout the movement through the nodular tissue. But success in RFA is typically defined in terms of volume reduction, with a goal of at least 50% volume reduction at 6 months and thereafter. There is an ongoing reduction in volume over time, and this continues even beyond the 12-month period per reports from our colleagues in Asia and Italy. Volume reduction can continue for up to several years. Success with functional or toxic nodules is slightly different. The goal is primarily to achieve euthyroid status off of medication, and secondarily to achieve volume reduction. These nodules tend to be hypervascular and are somewhat more refractory to the ablation and may require more complete volume reduction to achieve that euthyroid state. And it can take more than one session to accomplish this. Nevertheless, for most patients, one RFA treatment will be enough, and additional ablation may be considered for persistent symptoms, volume reduction that is suboptimal, as mentioned, or nodule regrowth, which, according to longer-term studies than we have available in the US, can occur in up to 25% of patients if you follow them long enough out, 2 to 4 or even 5 or more years. So to the topic of today's paper, in the introduction to this paper, there's a nice saying that these findings of surgery after RFA may serve as a catalyst for further exploration of the topic and spark some invigorating discourse, which I will launch into now. But as Emad outlined, his colleagues and he performed surgery following RFA in both benign and indeterminate nodules. And they compared 73 benign thyroidectomies that had not undergone RFA during the same time period, with a median collective size of the nodules at baseline to be 2.3 centimeters, with an interquartile range as demonstrated here. Some characteristics of the population in this study that might not be applicable to other populations that undergo RFA or surgery elsewhere are a relatively high baseline BMI, a median nodule size of 2.5 centimeters, which is a smaller median size than the average or median size in some other groups, including ours, as I will mention shortly. Emad commented on the median latency period to surgery being around 6 months, and I think analogous to when to perform completion thyroidectomy after a thyroid lobectomy, there is some advantage to waiting until inflammation subsides after the initial procedure. But I'm going to be interested to hear Emad's thoughts on the flip side, since there can be ongoing volume reduction even beyond 6 months and even beyond 12 months, whether surgical intervention might even be considered too early after ablation. The indications for surgery in this group were predominantly positive molecular testing, and other indications were mentioned here, persistent toxicity, regrowth, or patient preference. So on to some questions, and before I get into these in detail, I am just going to highlight the study that the Tulane group and the Johns Hopkins group and our group at Stanford pooled our data in a prospective multi-institutional North American experience to look at our outcomes at 1 year, which we are continuing to follow these patients beyond 1 year, but we adopted RFA in 2019, I think, as did our colleagues. And so none of us in North America have the duration of experience that is available in Asia, Europe, and even South America. But we did find that we had a median volume reduction of 70.9% in our patients over a 12-month period. And as Emad mentioned, the most favorable results seem to occur in patients with smaller original volume and a higher energy delivered. Overall, we found RFA to be very safe and effective. And so my first question for the current study under question of surgery after RFA is that the median collective size in this population for their nodules was 2.3 centimeters. And I just wanted to ask Emad to comment on the main reasons that these patients underwent radiofrequency ablation to begin with.
First and foremost, thank you, Lisa, for all that you've done for the field, and definitely always making sure that there are guidelines to help us with making sure that we are not going out of control, thinking of what we can offer, etc. And I really want to highlight one thing before I answer the question, that you mentioned it at the beginning of your talk, the ultrasound. You know, I went to too many meetings where, and for example, the AES does an RFA course, an ultrasound course, and one time the RFA was before the ultrasound. And I've seen surgeons register for both, and they're trying to learn RFA before they even learn how to do biopsies, which I think is a little dangerous. And we've seen strange complications and maybe suboptimal results because of this. I think surgeons are perfect to do this procedure because they know how to manage possible complications. But I think you need to really master the biopsies and have a mastery in learning ultrasound and FNA before just trying to jump into doing a procedure. So to answer your question about the size of the nodules, there's a good percentage of these patients underwent procedure for indication of hyperthyroidism due to ATN. So these autonomous nodules, they tend in general to be a smaller nodule. So in general, that can really deviate the median size to a smaller number. That's one of the reasons. The other reason is some patients will, for example, have a biopsy that can show atypia, and they worried about it, and the repeat biopsy can be benign. So I consider these as benign, and they might not be large, but these patients are interested in taking care of it. They don't want to worry about it. So I think we need to respect patient preference and do it that way. So I think that for these couple of reasons, there were some tendency to make it smaller. And maybe if the nodule, for example, not very large, but just increased or doubled in size, and some people would recommend maybe even removal, which I don't, but I think it's just a minimally invasive thing that can be done safely if the patient is interested, and it will make eventually my numbers tend to be like that. I'll tell you one thing though, right now, initially, as you know, when we started, there were a few people across the country that are doing this, and we used to get a lot of people flying in and all this, but to my knowledge now, there is I don't know, maybe close to 300 providers, maybe even more, who are offering this across the entire country. So promise you one thing, with my future numbers, they all like huge or cancerous. That's what I do now. I don't get the easy ones.
Well, along those lines, speaking of speaking of the huge nodules, I think we did identify that smaller nodules do have typically more favorable outcomes. But in my experience, patients who seek this procedure out are really fairly vehemently opposed to surgery. I mean, and that's why we see patients with such gigantic nodules, because they've been aware of their nodules for a long, long time. They would rather continue to live with those nodules than undergo surgery, but now there's an alternative. And so I guess that leads to my next question, which is for the non-positive molecular results and maybe for the non-toxic nodules that you had in your cohort. Did you consider a second RFA procedure before going to surgery? You know, many of these patients will do anything to avoid going to surgery.
I mean, you're absolutely right. I mean, I have to say that, as I mentioned during my presentation, that we keep learning about this. I presented an asset a few weeks ago when I looked at the meta-analysis for papillary thyroid cancer and the RFA. The best outcome happens in 1 year for cancer, not for benign nodules, which is a little different. So in order for you to see the best outcome, you might want to wait for a year. But if the patient do not have, like, the response is not really impressive, yeah, it might not grow. But you are right. I may be rushed into surgery, and maybe if I waited a little longer, maybe they would responded. But some of these patients, they paying out of pocket, and they might not be excited, and not everyone can afford the second to pay for a second procedure. And even for the first procedure, I have patients. Listen, I live in Louisiana. I have patients that I think they are perfect candidate for the radiofrequency ablation and small nodule ATN. And unfortunately, they will undergo surgery because they do not have the ability to afford the procedure. So it's as you know that now they work in the CPT code, and maybe this will change in the near future. But you are right. Maybe I rushed on some of these cases, but I feel like we all keep learning through this process. And as you know, there are many things that were kind of absolute contraindication or relative contraindication that are not anymore. For example, bilateral nodules, it was not recommended to do bilateral nodules because of the risk of putting both nerves at risk. But I recently published a series on ablation of bilateral nodules, as long as they're far away from the nerve and it's safe. I feel like there's a lot can be offered for patients. And then we focus significantly on radiofrequency ablation. So for example, there's certain contraindication like pregnancy or pacemakers, etc. But now we know that there are bipolar RFA outside the US, but you can maybe put a magnet in the patient. But also now we have the microwave option that's also FDA approved, that it can be done safely for these patients. So it's really an evolving field, and more to come. Since you put up the slide, the molecular, that's another interesting topic. So yes, a lot of these patients will have a biopsy, and I'm sure you've seen a ton of these. I have patients that had benign biopsy, and they come to see me, and I'm like, I look at the nodule, I'm like, I need to repeat the biopsy, and it turned out to be malignant. But as I said, a lot of these patients, they already have biopsy outside, and before I do the procedure, I will repeat the biopsy. But if they turn to be positive, these patients underwent surgery, and but in general, that's another interesting topic, the molecular markers. So, we used to be even careful performing radiofrequency ablation for indeterminate nodules with negative molecular results. Now, everyone, to my knowledge, offer it. Because what else we do? We actually observe these otherwise. So now at least we can do something to it. The positive markers, many of us, including myself, are offering it carefully for certain patients with certain mutation, need to learn more about the mutation and the risk and observe them closely and all the kind of things. And that's a very controversial topic, and I'm happy to talk more about it if you want to. But again, many of these patients, as you said, they've been sitting on a nodule with a positive molecular marker for years before the RFA, and they refuse to undergo surgery because the risk of cancer is 50%. I'm sure you've seen many of these patients. 50% doesn't make them sign up for surgery. So I think they have the options. And what I found that what I will tell patients when I counsel them, if we do not see an excellent response and excellent results, then you have no other option except surgery. But I also repeat the biopsy, and I prefer that they have it repeated by the same center or place that they did, so they can find what's going on. And what's really interesting, cancerous nodule or suspicious nodules, with a repeat biopsy, you can get one of two results: either benign tissue, there's no more cancer cells, or non-diagnostic because it's just necrotic cells. So and I've seen many of this, and I had examples of this for sure. So it's something that we need to think of, like really how many times we've seen like a 1 centimeter nodule or so around that size with a positive marker that will really eventually can be aggressive and metastatic, etc. And if I can make this nodule literally disappear, why not?
Yeah, I think I have a typo in this slide. This should be the PRT group, your previously ablated group that had molecular tests and went to surgery. I guess my question here was maybe more about the timing. I think when you discussed it today, it sounded a little different from how I interpreted what you published, but it sounded like you did the biopsy at the time of RFA, so that you sometimes getting these molecular results takes, sometimes a month or more. So if a decision about surgery or no surgery hinges on the molecular testing, did you proceed with RFA anyway based on the first benign biopsy, and then decide that since the molecular test ultimately came back positive, that this patient would be better served with surgery?
So in this study, there was only looking for benign nodules. So when we offered these patients the RFA, they were all like benign, but the repeat one at the time of the RFA end up having positive molecular test. And I tended initially, in my experience, to not to offer RFA for positive molecular tests as I do right now. I've been doing this since 2020. When I saw a positive molecular test, I said, listen, we did not know that this has a positive molecular test. This is a problem. You need to have surgery. So I did not wait on outcome on these patients.
Mhm. Good. Well, this is exactly the kind of data that we need to publish and share so that we have more insight into the behavior and the appropriateness or not of these
Yeah. I'm
so-called
about,
indeterminate
yeah, I think it's a very,
nodules. I think that, there are small studies published, one from Italy here that described indeterminate nodules that underwent ablation, and an impetus for proceeding to surgery in spite of negative molecular tests was regrowth that led to surgical excision and revealed minimally invasive follicular carcinomas, which of course we don't want to be missing malignancies or applying RFA for what we think is a benign nodule and have potential undertreatment or different follow-up than we would have offered for a known malignancy. But even in this study, as you published, there was no increase in difficulty in the surgical procedure after the ablation. My personal experience with surgery after ablation is only with autonomously functioning nodules, and my anecdotal experience is exactly the same as yours, that there was no increased risk of complications, no increased difficulty. I think, as you nicely point out, the fact that we try to keep the RFA needle inside the nodule and not damage the exterior of the thyroid gland. And we use hydrodissection, which I think also helps to minimize thermal damage to the surrounding tissues, lends itself well to preserving the exterior and the surgical planes when surgery is necessary.
100% agree with your comment about the hyperfunction nodule. And I had that actually.
Mhm.
But that's what you expect. Like, it's not because of the ablation. So this large autonomous nodule that did not respond to the RFA, it's not like gonna be the one that just gonna peel off. But I did not, it's like what you expect. So we actually, in this study, we made sure we compare apples to apples. So we had similar number that has the same thing. Yeah. But as you know, it's
Yeah.
not like, yeah. It's not like a mess or you go in and it's like there's like a disaster happened there, what people were thinking. It's just, you can tell there is something happened, maybe it's a little scarring. And I think if you also pay attention, but it's not bad.
Lisa, and Emad, can you comment on
Yeah.
how close a nodule is to the capsule that you would consider that to be a safe nodule? Because it seems like that everything really depends on the position. And one follow-on question related to the hydrodissection technique. Are you hydrodissecting posteriorly or just laterally? And one last question related to that. Have you ever considered, or has anyone done research on putting a temperature probe into that hydrodissected volume to look at the temperature generated outside the thyroid? Yeah, let me just stop there and just see if you could comment. One is nodule position, the second is posterior hydrodissection, and the third is temperature within the hydrodissection.
So I think this is all important questions. So regarding the location of the nodule, when people say it's close to the carotid, it's an issue. I don't think it's an issue at all. You can make a huge distance between the nodule and the carotid. And the biggest concern in my mind is the closure, to be close to the dangerous triangle where the nerve enters the cricothyroid membrane. And in these, I will have a discussion with the patient that I'm going to be very careful. This is not going to be, I cannot get a margin. I will leave maybe a little bit close to the nerve. My goal is safety here. But if it's near the capsule, you do a lot of dissection. I still don't want to burn too much. I'm always in my mind very concerned about the rupture, and I don't want to ever want to have one of these. Thank God I never had one yet. But I think it's the key is to not to do multiple entries, to master how to do like a moving shot technique, and try to not to go too much over the nodule, over the capsule. You can burn a good margin around the nodule with the capsule. But you know, there is no studies also looked at the margin effect, like if you do 1 or 2 millimeter versus no millimeter. We just think it's better to just burn everything around it. This anecdotal recommendation. Regarding the
So
hydrodissection, yeah, go ahead, Susan.
well, I think that this is the competing challenges in order to prevent regrowth. And in light of the fact that many nodules have the predominantly peripheral vascularity, we try to ablate that peripheral vascularity, but that's the capsular area where there's the risk of breaking down the capsule and enabling rupture. And I agree with you, Emad, that the site of needle entry is all important. But we've just submitted for publication our experience with rupture, and so our growing impression is that the heat delivered at that needle entry point is overall greater than throughout the rest of the nodule, because as you're doing the moving shot, you continually withdraw your probe back to the site of entry, and it's important not to continue to deliver energy at that superficial entry point over and over again as you're moving through the nodule. So I think, Mark, your question about location is all important for everything that we do with RFA. It influences how completely we can ablate a nodule, whether it's appropriate to ablate a malignant nodule based on location, whether, you know, how close it is to the recurrent laryngeal nerve. I think one point I'd like to make is that I agree with Emad that the carotid sheath itself, the carotid artery, has such high blood flow that it is a heat sink and is not prone to thermal injury as a vessel. But I always now look for the position of the vagus nerve within the carotid sheath, because sometimes the vagus is positioned medial to the carotid, and that's vulnerable to heat in a way that the carotid is not. So again, it gets back to the ultrasound and not just looking at the pathology, but looking at the normal anatomy surrounding pathology that helps keep you safe. Your idea for a temperature probe is fabulous, though. I don't know that anybody's done that, but it would be a great study to assess the temperature in the vicinity surrounding the thyroid. I think that would be a really meaningful measurement.
I just want to make a quick comment about, before going to the third question, about the post-surgical, the surgical experience after RFA. So the study was done for benign nodules, but I tell you, like, the few cases that were cancerous or suspicious for cancer that I end up operating on, they were like bad ones. And I tell this to patients when I counsel them, like, listen, if you do not have an excellent response to the RFA, then you do have a bad cancer. And instead of doing a lobectomy, you actually need a total thyroidectomy. I will do maybe a prophylactic central dissection. And these tend, when you go in and operate on them, to be tough. I don't think it's not related to the RFA, but because the tumor is really a bad one and stuck to whatever tissue. So I think that's really important when we discuss these with patients. I forgot the third question, Mark. What was the third question?
Oh, hydrodissection, I think. Yeah, hydrodissection posteriorly.
Oh, yeah.
I do some hydrodissection posteriorly, but not to the degree that I do anteriorly and laterally.
Emad,
I don't know, Emad, if you do the same.
So what I learned from actually Chinese colleagues was really interesting. The trick to do it is to have a very long needle to get there and push it. So And again, we are surgeons. We know thyroids are not the same. Some of them are adherent, some are not. But the trick that I learned recently is to use a long needle to get posteriorly and do the hydrodissection. Anteriorly and laterally is very easy. But to do a good hydrodissection laterally is a simple trick, long needles. It was just amazing to learn that.
Unfortunately, Emad and Lisa, we're up against the 9 o'clock hour. I think we could probably continue to talk about this for another hour. But I do want to thank both of you for your comments, for your presentations. And Emad, really appreciate the time and effort. And Lisa, you as well, and especially for getting up at an ungodly hour in California. So thank you both, and want to thank everybody for joining us, and look forward to hopefully you'll be with us next week, same time here. Thanks, everybody. Take care.
Thanks, Lisa. Thank you.
Appreciate it.
Thanks very much. Thank you all. A pleasure.